Good morning. It is Friday, April 19th, and this is a joint committee meeting with the Education, Culture, and Health and Human Services. I'm here with my friend and co-chair, Councilmember Albornoz, as well as Councilmembers Lukey and Sales, and Councilmember Mink is on her way. We have a hefty agenda that I'll just be up front. We won't get through today. We're going to be ending early because several of us need to go to a press conference about the averted mass shooting at Wooten High School. So thankfully everyone's safe. But we need to, there's a press conference that we're required at. So we're going to start with the Newcomers program and then start the conversation on, and we think we can get through that, and then start the conversation with early care and education. We're going to have to come back to it at a future joint. We have another scheduled, and if we need to schedule another one, we will do so. So appreciate that. Several of us just came from, I'll just say quickly, from Madison House Autism After 21 annual fundraiser, and just a reminder of how important acceptance and services for our entire community are, and particularly from our youth as they transition into adults, and just really appreciate this committee and this council's work. We are trying to make sure people have what they need, to get from early childhood all the way through career. So I'm going to turn over to my co-chair, and then we will jump into the packet.
Let's jump in.
All right. So let's do the Newcomers. So I think for that item, it's going to be council staff will lead us off.
Yes.
All right.
Thank you so much, Chair. So we are starting with the Newcomers program. The FY25 recommendation is $7 million and 12 FTEs. This is a difference of around $700,000 from last year. It is listed as a one-time only item, but the program has been funded for a number of years. The funding this year is utilizing FEMA reimbursement dollars, but essentially general funds dollars. The Newcomers program is a collaborative initiative established to assist unaccompanied minors, youth, and families seeking asylum from the southern U.S. border into Montgomery County. The program has been in place for a number of years, providing services through the navigation network. The partners include DHHS, MCPS, and a number of our community partners to provide services like food, access to health care, and mental health services. Beginning in spring 2022, the regions started to experience an influx of migrant individuals and families being bused to the region in protest of Biden's administrative policy decisions. Montgomery County became involved in helping to assist those families initially through the Newcomers Network. And in June of 2022, the county established a respite center with SAMU First Response, providing centralized respite support services. The migrant families that are coming intend to have a short-term stay, 3 to 5 days. So their work is a bit different than newcomers who intend to stay and reside in the county. For FY25, the program is shifting to a new model. The first program, it's broken up into two programs. $5.7 million to offer intensive case management, navigation support, and innovative group mental health for newcomers who entered the country after April 2022. And then Newcomers, then the other version of the program, which is funded at $1.3 million, provides supports to individuals who arrived prior to April 2022. So basically, the old model of serving mostly the unaccompanied minor children and that we're trying to settle here with sponsors and families is funded at $1.3, and the new model is more expansive, recognizing that some of the migrant families are staying here and would like to stay in Montgomery County. So that effort is the $5.7 million. In your packet, the budget items are listed. I just want to note that comparison from the budget last year, there was the removal of 2 FTEs and also the removal of three main budget items, which are the street outreach under SEF, the removal of Safe Center education regarding human trafficking, client service emergencies, short-term transitional lodging. The significant increase in FY25 is for intensive case management support. That budget went from $350,000 to $1.6 million, and there's new FY25 funding for mental health services to the tune of $1.3 million. The committee may want to discuss the reason for removing the budget items that were mentioned, and council staff's recommendation is to approve as recommended.
Thank you, Ms. Clemens Johnson, for that overview. I'll turn to our HHS partners and to my co-chair, and then if council members have questions. I'm just so proud that we're doing this and that we've done it. Several of us have visited the border during our last term and also the center here in D.C. and have seen it, visited the arriving buses. Again, not a problem of our making, but we were among the first to step up and say that we're going to provide humane arrival and support because it's the right thing to do. And these are our neighbors and community members. And I was chair of Region Forward for the national for the region of governments last year, and we worked hard to get other partners in the region, and DC has helped, but even our folks in Virginia to step up and help. So I really just want to start by saying I'm proud of being in Montgomery County and the work that our HHS has done with the nonprofit partners. Do you want to give an explanation, I think, just briefly about why the -2 FTEs and what the strategy and how it's changed, and then we'll turn to colleagues.
Sure. Good morning, EC Chair Jawando, HHS Chair Albornoz, Councilmember Sales, Lukey, and Mink. This is probably the most you will hear me talk this morning because we have a large contingency behind me who are actually going to talk to the granular level of data that's contained in the packet. Ms. Rosarian will actually walk through the packet, but I would be remiss if I didn't thank our partners, as you indicated. And I wanted them to hear me say that this morning because the work that we do in HHS is complex. We need to move or realign those resources that speak to the community level need. And this is one of those programs where we made the adjustments. So I'll stop there and I'll turn it over to Ms. Rosarian to actually provide the details of the shift.
Good morning, everyone. As Director Bridgers mentioned, we are working to realign the program moving forward, having learned some valuable lessons during previous iterations of Newcomers. So we have expanded the naming convention of the program, so to reflect the fact that individuals from various regions of the world are coming in. So we want to make the program as broad and inclusive to all newly arrived individuals as possible. So we firmly have branded the program Newcomers moving forward. And our work has really centered on best aligning the resources that we have, both staff dedicated solely to the Newcomers program, as well as the monies coming in and our coordination with our partners. So some of the changes that are being made have been in consultation with external sources, subject matter experts, looking at how we've worked over the last couple of years with our community partners, our dedicated community partners, as well as how we can best realign our internal supports and services. So some of the moves that we're making look like reductions, but they're really realignments and efficiencies that have been made over the past few years. And so we're very, very proud of the work that's been done internally and externally with our community partners to really help with the resettlement process of the families that are coming in. We are seeing a fair number of families who want to remain in Montgomery County, and we realize that some of the resettlement services include case management, workforce navigation, assistance in enrolling within MCPS, housing support while individuals figure out their next employment steps, as well as coordination with the federal government in relation to seeking permanent status. So those elements that I've just briefly walked us through really speak to the families that are coming in and wishing to stay within the great county of Montgomery. But we also have some families that stay within the respite center, as Ms. Clemens mentioned, for a short amount of time as they transition to family members, community connections in other parts of the country. And so we assist with those transportation needs. So the work that we're doing with SAMU to welcome and resettle and get those families comfortable and in a safe space to share their stories. And so then we can figure out how best we can support their next steps. And with that, I will pause to see if there are any questions.
Thank you. I'll turn to Councilmember Albornoz and just want to say this is a joint committee for many reasons, but on this item in particular, many of our newcomers arrive with young children. And MCPS has had to set up and stand up and build out an infrastructure to make sure that we're addressing the needs of all of our children. So with that, I'll turn to Councilmember Albornoz.
Thank you. I want to echo the, once again, gratitude for all the folks that are on the ground, rolling up their sleeves, doing the heavy lifting in this work. I've said many times, I know my colleagues agree, I believe we have a moral responsibility as a jurisdiction to take care of everybody within our borders, regardless of how they got here, and through no fault of their own. But beyond that, there is a practical reality that these folks are going to come because of an imminently broken federal immigration system, and it's incumbent upon us to help process and help to transition them in a way that helps them and our entire community. Because if we're addressing their needs before they are in complete crisis and are able to access programs and services that they are in fact entitled to, it helps everybody. And I also think and continue to strongly believe that it's in our own best interest, as was very eloquently stated just now, to help and assist families that are coming through Montgomery County but not necessarily staying here, because it helps everyone in that regard. So I did have just a couple of questions, and the data on where primarily these folks are coming from is from FY23. The world has changed significantly just in the last year. And so I'd be curious as to, and you don't have to provide right now, but I'd be curious as to where folks are coming from now, what updates we have now. And although we've heard from our friends in SAMU who testified during the public hearing that while the buses may have slowed down specifically, people are still coming, and coming in a variety of different ways and means. And so at a later date, Chair Jawando, I'd love to follow up once the dust settles a little bit to get an update on where things stand currently so we can have a longer operational question and see where we go from here in terms of transition, because this is a constantly evolving situation. And let's be candid. We have a federal election on the horizon that may further impact our work. And we have to have our eyes wide open about that too, and prepare for what comes ahead. So.
Thank you so much for that question. Will be very happy to provide the FY24 summary. Thus far, we have in our packet the 23 information. It will not change significantly in FY24, but we're more than happy to provide that information. To follow up on that question, we absolutely are seeing shifts. So we've seen a greater increase in Haitian migrants coming into the county. So you'll probably see that new addition to the FY24 numbers. The shift is really in relation to climate-related needs that are happening in home countries, geopolitical actions that are happening, wars that may be impacting and influencing folks to come into the country, as well as frankly stated, our immigration policies, our need for updates to the immigration policy, fears about what may happen during the next election cycle. So we are seeing some shifts, and we'll be more than happy to provide detailed information about what FY24 looks like. However, I do want to make a plug for the fact that we are actively working on developing a database that will be able to, next year when we're sitting in front of you, to provide information about families coming in, size of families, how long the resettlement process takes, the length of stay at the respite center. So recognizing the vulnerabilities that are within our data collection practices at present, we have been actively working with our HHS IT team to develop an in-house database that will be shared and used amongst our partners to assist with the referral process, collect demographic information, so then a robust data set will be able to shared with the council, still respecting the privacy and confidentiality of the families coming in, of course. But we absolutely know that data is king, and we want to make sure that we have access to really reliable data to support the needs of the programs moving forward and any other programmatic or policy shifts that are needed.
That's great. I'll just make two final points. I appreciate that, and we will have the follow-up. But we've been able to avoid the politicized fight between the federal government and local jurisdictions because we have been true partners with our federal partners, and that can't be overstated. And this program has been lifted up by the administration as an exemplary model, and that's something that we should all be very proud of. And I'll also note as well, I have seen a discernible positive change in partnership with our colleagues at the state level as well under the Moore administration. And so that will also be helpful and has encouraged other local regional jurisdictions to join us in this effort because for too long we were almost by ourselves. But they're coming on board, which is great news. Thank you. I yield back to you, Mr. Chair.
Thank you. Great points, and we will definitely have a follow-up. Councilmember Mink.
Thank you. So as has been mentioned by my colleagues and by you all, we have different and changing diverse needs. We're seeing that obviously a lot in my district, in District 5, where we have influxes of immigrants from Afghanistan, from Haiti, from many different places. So could you say a little bit more about how you're working to address those specific needs in relation to those different populations, different languages, and those sorts of things in the new model?
Thank you for that question. Recognizing the fact that we have diverse groups coming into the county, we are reaching out to various community-based organizations to assist with the specific cultural needs and language needs of the various newly arrived individuals coming in. We also are working closely with the Office of Community Partnerships that are present and infused throughout the community to assist us in identifying those grassroots organizations, to assist with the services and needs of specific populations that we may not have in-house capacity to support. Faith-based organizations have very much been present and committed to helping the newly arrived individuals who elect to stay within the county or are transitioning through Montgomery County onto permanent locations. We also recognize that moving forward, we want to establish partnerships, formal partnerships, contracts with a diversity of community groups working within the county to speak to the needs of the Afghan residents that are coming in, the Asian residents that may be coming in, and we may not have that in-house support at the moment contractually to support those communities, but we're looking to, and our COO may be able to speak to this a little bit more within FY25, establish a broader base of contracts, a more diverse mix of partners to assist with the varying needs of the newly arrived individuals coming in.
Yeah, that's great. Oh, did you want to say, please?
Yeah, one of the things that we are making a concerted effort to do is to rebid all of the contracts associated with newcomers. We know that initially we needed to use existing contracts to get this up and running as quickly as possible. We now have the opportunity to be a little more picky about the types of services we provide and who we're providing them to. And so while we may have two partners now who have been doing all the case management and resettlement and have been doing an amazing job, there are new populations that are coming in now that need to be served in a different, more culturally appropriate way. And so we are going to expand the number of contracts we have to provide resettlement and other case management type services in order to do that with the right languages and with the right culture.
Appreciate that.
Councilmember Meek, just to add, I also want to thank Ms. Treadvance and Dr. Mensah and our Children, Youth, and Families Service Area for shepherding this body of work initially when it was focused on unaccompanied minors, but now the shift to the Office of Community Affairs with Ms. Betty Lamb affords us, the agency, the ability to be more inclusive. And so part of that realignment and strategic initiative is part of our strategic plan, looking at our strategic roadmap. So just contextually, just to look at the shift so that we can have a wider reach in the community is part of that decision-making at the executive level.
I appreciate that, and certainly as we circle back on this, it would be great to take a look specifically at the different partners who you're working with. You know, in some cases, there, you know, it might be an addition of a contract. You might have a contract with a partner who's really great at serving and reaching this population, and now maybe that's going to be a little bit less, and you're going to show some love to this community here. But it'd be great to understand specifically how are you reaching each of these different key communities in a culturally responsive way. Where are you hiring up folks who speak different languages, and where are there budgetary needs that we need to think about for the future where we would like to be doing more. Mental health is one particular area that I know we have all heard about where there are great needs to find appropriate ways to reach each of these different populations who are coming over with their, you know, particular traumas and backgrounds, and having culturally responsive mental health care that they're able to reach for both our young people and the adults is really, really critical. And it can be hard to find the right partners, and it can be hard to scale them up. But I think that is a really high need to circle back on as well. As has been mentioned, also MCPS is also being responsive to this enormous increase, and they're building out their international office. So it would be really great, I think, if the committees could have, you know, the MCPS international office alongside the newcomers to kind of talk about the collaboration that you're doing. And I know some of that you're going to be sorting out, you know, over the coming year, but wanting to make sure, obviously, that those pieces are integrated and that there's an understanding amongst the council and amongst the public with how those pieces are working and the way that you are thinking about being strategic, enhancing each other's work, sharing data, all of those sorts of pieces. Also wanted to, you know, give a shout out to, you know, of course we have partners, departments, agencies, lots of people who are engaged on this issue. In particular, I wanted to note that in the outcome of an issue that we had at Blake High School, which included some of our newcomer population, some of our non-newcomer population, but with thanks to MCPS, to MCPD, and to the Street Outreach Network, who really jumped in and collaborated on that. And the Street Outreach Network had, you know, standing relationships with some of these populations, so it really emphasizes the importance of making sure we're all working very closely together. Thank you.
Ms. Lambert, you want to say?
Deborah Lambert from the Office of Management and Budget. Councilmember Mink, I just wanted to let you know that in the proposed fiscal year 25 operating budget for newcomers, we have allocated $1.3 million for mental health services, to answer your question about mental health.
That's great to hear. And I know that's something that has been not just on your mind, but in action, and look forward to, I don't think we need to do this now, but to coming back and really looking at how you've thought about that, and making sure that you know, we fully understand what we're looking at budget-wise next year, and how we can help to connect our residents over the coming year to culturally responsive and appropriate healthcare and mental health care. So really appreciate that, and look forward to hearing more about how you all are using it.
Yeah. And $587,000 for navigation supported MCPS, right? So to your point of making sure we talk about that more. Councilmember Luque.
Thank you. I'm not sure if this is mine or not, but I'm gonna borrow it. Okay. All right. So thank you, and thank you, Councilmember Mink, for raising the issue with respect to the need to be flexible over time in how we're addressing things. And so to that end, my ask is, understanding you had to rely on existing contracts before in order to get things, pushed out. What steps are you taking moving forward to make sure that you have agility in the contracts baked in that will give you programmatically that ability to be flexible without having to redo agreements or do new contracts?
Yeah, so the contracts we have, existing ones that we have been using, have very little flexibility.
Yeah.
And we were able to change the scope a little bit, but we will make sure that we build in, knowing that we only have funding for 1 year, that also makes, from a contracting standpoint, a little more difficult. But we'll make sure that the contracts that we have are able to be adjusted and amended to add new scopes or to take things away as we continue to refine the services that we're providing. We know that each different population who's arriving, even though they seem to all be arriving through the southern border, regardless of where they're from in the world, that we are able to manage them, case manage them in a way and get them resettled in a place where they can be successful. And so part of the contracting, the parts of the contract that will have people bid for, hopefully will also allow them to use their own, the nonprofits use their own abilities to guide us in the contract as well. So it won't be so prescriptive that we are telling them how to do it, but other nonprofits have been doing this. Some nonprofits have been doing this far longer than we have, and may have a good idea about how to do the contract on our behalf. So it'll be more of a general language type stuff that we can refine. But yeah, we're hoping that the nonprofits can also assist us in that.
And no, I certainly appreciate and understand that the funding is for a budget year, right? But there is the ability to add language in there that makes it contingent upon funding for subsequent years. And again, doing things like adding an addendum to it where you can break out the hypothetical additional buckets of stuff that you might need to refer to, if that's there as a menu, if you will, to be called upon in the time of need, then that will help you a lot with having that level of flexibility moving forward. I also want to shout out our faith-based partners and groups like the Scouts troops that have done, adopting families as they're now transitioning into their new place, and helping them get set up with housewares and stuff like that. I know that's something our kids did, or helping actually with the move, like my church had the sign up genius, and everybody sign up, this is moving day, this is what we're going to do, which is great because we can't do this alone, and our nonprofit service providers can't do it alone. We do rely on our other community groups and lots of elbow grease and manpower out there that comes straight from the heart to make sure things are working. And I serve on the Human Trafficking Prevention Committee, so I want to thank you, Dr. Bridgers, for highlighting why this was moved to the Office of Community Affairs. A lot of folks think of human trafficking and think of young people, and that is a population that is exceedingly vulnerable, but trafficking involves people of all ages, both labor and sex trafficking, and it's incredibly important to not lose sight of that, and it's not a gender-specific thing. And thank you for the comments about the mental health services. I think it would be great, and if we come back at another hearing, not budget related, but to give us a sense of what the initial triage is, because of course there are certain things you're going to want to be looking for, and no, there may be grief counseling needed, there are other upheavals, there's anxiety. So the types of things that are standard across the board that would be assessed for as people are coming, and then what sort of the flow from there is based on the level of need in that mental health space. That would be very useful. And to Chair Albernaz's point, yes, the federal government has been grateful for everything we've done, and the state is a much better partner now. But I think it's important for us to remember and remind that this is the situation we have comes from a longstanding challenge with immigration law as a whole in this country that has not been addressed. And over the years, things have been layered on and nothing's been decluttered, if you will, right? And so we're in a predicament where we have an outrageously complex system that doesn't really work well for anybody, and creates a level of time and effort and energy to help those who are trying to come, who need to come. And my ask or my hope is that we are able to try to leverage financial assistance from the federal government. Since we do it well, we do great things. We are here, we are ready to do them, but this is the immigration law and the immigration system is the federal government's responsibility. We can care for the people. Please help us to do that work because we can't do it alone. So thank you.
Thank you, Councilmember Lukey. Great points. Do you have a comment? Okay, Councilmember Sales.
Thank you.
Your mic isn't on. Go to the left.
Oh,
There you go.
thank you. Okay. All right. Thank you so much for the briefing. Just wanted to get a better understanding of how long it currently takes to resettle a family on average.
That is a complicated question, but thank you for asking. So it depends on the family dynamics, the size of the family, skills that were brought with the family to the country. So we are seeing resettlement occur 6 months, 12 months, 18 months. It depends on, where there are traumas that need to be addressed. The family's ability or the parent's ability to gain employment, to get work visas. So that's a critical piece. Access to a work visa really is a linchpin to the resettlement process, because without being able to be gainfully employed, families have to get creative. And so we have some families that come in and, process all of the requirements. The stars align in terms of appointments with the feds, getting a work visa, and then being able to gain employment, and then can cycle out of our Newcomers program and just may have to or may seek services as needed from nonprofits in the area, from HHS at large, or faith-based organizations. But then there are others who may have longer durations because they don't have access to a work visa, because there's some significant traumas that need to be addressed. So with the creation of this database, we're going to be able to provide an average, a snapshot of what that looks like. What are the steps that enable, that are common within the families that, have a streamlined process to resettlement, have followed? What are some of the barriers that we're seeing that delay the resettlement process? Our goal is to have resettlement occur within 18 to 24 months. But we know that if someone is new to the country, there are language barriers at times, there's understanding bureaucracy, there's just, learning how our systems work. And so you're resettling for many years, but in the greater, definition of resettlement. But for the purposes of this program, we'd love to see families fully resettled and independent between 18 to 24 months at max.
Okay. And where do they go when they come to the community? Where are they staying?
We have some families that, they come to the respite center if they don't have familial connections or friends in the area. Some come with friends and families in the area. But we also work internally with our office of our SEF division, Services to End and Prevent Homelessness, and they're able to provide supports, rental supports, establishing helping the family establish and obtain a lease to get their own apartment or sublet, and then assisting with several months of financial assistance while they work on getting the work visa, and getting the kids settled with an MCPS, and learning their way around the region and the county. So we have some families that come and stay with family and friends or work with us, and we work internally with staff to assist with housing stabilization.
And so have we navigated what the barriers to obtaining the work visa is? Is it the court system? Do we know have we identified what the barriers are to
There
accelerate?
are many barriers. I think there's a backlog, and sometimes there are documentation challenges. So those heavily influence how long it takes for individuals to acquire work visas. And there are many other barriers to one getting a work visa, but our families are entrepreneurial, and while awaiting the receipt of their work visa, they find interesting and creative ways to gain workforce experience.
Okay. And then I believe when we're going to get more information on the nonprofits and faith-based organizations
Yes.
that are assisting the individuals and families. And how many families do we currently have at the Respite Center?
Volume has been reduced since the buses have ceased over the last few months. At present, I can share with you, I have to go back and look at what the present day count is. I can share with you from July through March 31st of this year, we have had 144 referrals of family units. So that's a family unit intact, but that family unit may be 600, or the total number of individuals within that family unit may be 500 to 600 individuals, since we have, mom and dad and several children coming together. So I will go back and get the current count for what the volume and residency status is at the Respite Center. But right now we have several hundred that have been referred into HHS for navigation case management, and that is north of 500, 600 individuals for the year that have been connected to resources within Montgomery County.
Yeah, it would be good to understand what the current population is and how long that track record is for each of those families, so we have a better understanding of how we're budgeting the resources for these families moving forward, and how often you're checking in to reevaluate the count of the current families.
Absolutely.
Okay.
So I will also share before we continue on, the stay at the Samuel Respite Center varies. So as mentioned, some families stay there for 3-4 days and then transition out into other living arrangements. Then we do have some families, especially those who are interested in staying in Montgomery County, who take a little bit longer to, locate housing, establish a lease, coordination with staff. At the end of the day, families cycle out before the 30 to 45 day mark. But for those families that are transitioning through Maryland to get to, say, Baltimore, or to they have family in Northern Virginia or Chicago or New York City, the stay is much shorter. So it really does depend on what is the ultimate goal of the family. We work with the family to ensure that we're helping them achieve their self-identified goal, and help them, relocate and transition and travel as needed. But then those families that want to stay here with us, it's a little bit more intensive, and it takes a little bit longer for us to help them find housing, get into a school that they like. That coordination with MCPS is critical. And so that's where we have, and we're grateful for all of the support from our respective service areas within HHS to assist with all of those resettlement related needs.
Thank you so much, and thank you for the change in the name to make it more inclusive and accessible to everyone who comes to our community seeking help. Thank you.
Thank you, Councilor Sales. Thank you for the update. As we mentioned, we'll come back in non-budget time to go deeper into some of these items. So we have a staff recommendation for $7,155,143 in this year's budget. Any objections? No. So without objection, we thank you for that. Considering our timing, we're going to move now, jump a few steps to the CIP for items that we left at our last session. Apologies in this, so we will not get to the early childhood today. It's clear to me now. So I think we have a session next week on Wednesday. So we will do that presentation. We want to give it the air and breath it deserves. We will do that next week. So we're going to move to the CIP item for school-based mental health services. And Ms. Xiao, I'll turn it to you for that. We had a couple of outstanding questions, right?
Yep. So for the Joint Committee met on March 21st and reviewed 5 education-related DHHS CIP projects recommended by the executive. And there's a summary of what the committee did in that meeting. So they recommended unanimously approval of the child care renovations projects and there's 3 of them: ADA remediation, child care facility replacement, and playgrounds. For the high school wellness center and expanded wellness services project, the committee recommended approving the executive's recommendation for the Springbrook High School Wellness Center, approve the Paint Branch High School Wellness Center, understanding that the project may be put on hold if the school construction project is delayed, approve the executive's recommendation related to mental health and PYD space at Magruder, Blake, and Crown High Schools, not to move forward with the full wellness center at Damascus at this time, needing data substantiating the lack of student health care access and priority over other schools in the queue, and then programming mental health PYD space at Woodward High School. The committee requested that the program of requirements for mental health PYD space be transmitted to the committee. The committee also recommended 5-0 for the school-based health and linkages to learning centers project, basically concurring with the executive's recommendation for the 7 projects, but updating the PDF to make sure that it was current with the current CIP schedules. So an updated PDF is included in your packet at circles 3 to 4. Also, the committee recommended adding funding for feasibility studies for standalone linkages projects at schools that have more than 600 students and more than 65% of the student body enrolled in farms. There's a list of various information and follow-up that the committee requested that's bulleted at bottom of page 2 going on to page 3. So coming back to the high school wellness center and expanded wellness services, subsequent to the committee meeting, executive staff indicated that a full high school wellness center was needed at Woodward to provide continuity of services for the Northwood High School students who would be at Northwood starting next school year. Apparently efforts have been Woodward, sorry. Yeah. Yes. I'm sorry. Anyway, efforts have been underway to prepare the wellness center space. Consequently, council staff recommends that the committee support the original recommendation to program the high school wellness center at Woodward.
When we pause there, I think it makes a lot of sense. I don't know if colleagues have, kids from Northwood are moving over. That's our first school-based wellness center. They need the services. I think it makes sense to build one there. Any comments or? Okay, so without objection.
Okay, there was some updated information that was requested from the committee about the number of students who access high school wellness centers that have access to health care services through insurance or Medicaid, and that information is provided in your packet at circles 5 to 8. It does show that about 11% of visits at existing school-based health centers and wellness centers are from students that have access to health care.
11%, right? So the vast majority do not have access to health care.
Also, there is a schematic of the mental health and PYD space as well as the somatic health space at circle 9 of your packet. So that does show you, what the build out would look like if you had a full center or if you just had the PYD mental health space.
So Yeah, I want to let Councilmember Mink ask the question she just whispered to me. So you better say the same thing.
I'm going to say the same thing. I'm going to say the exact same thing, which was a reminder that I wanted to come back to a conversation that we started when we were looking at, I think it was when we were looking at the CIP around wellness centers. But that was in understanding this plan or intention to scale back some of the wellness centers in order to accommodate or make sure that we're not, putting our private practitioners out of business. And we talked about, we asked for those numbers because, I was wondering, are we really taking that much business from our private practitioners, or are we serving the kids and families who are not getting served elsewhere? And so from those numbers, it looks to me like I would not think that we would be taking a lot of business from those private practitioners, certainly not something that's going to break the bank. And I would have great concerns about limiting access or making access more difficult for an already vulnerable population for which we've seen that this type of programming works really well. So is there, in light of those numbers, are there thoughts about rethinking that plan? And if not, I would definitely like to come back to this to understand better the impact that this could have on our community.
So just so I can clarify something, the numbers of students who have private insurance at the schools where there's currently where they currently have wellness centers are placed in places by design in schools that have low access to begin with. So communities where low access to care exists, or large numbers of students with Medicaid, or large numbers of students who are uninsurable. And that's why we put them in those places to begin with. To move them to places like BCC and Wooten and Walter Johnson and other schools where there's a much higher percentage of students who have private insurance would change the numbers here. I'm not saying they wouldn't need to access or there aren't students who wouldn't need access to those services in those schools.
I think that's
but the numbers,
right there. That's the key point, though.
I'm sorry.
What you just said, though, I think that's the key point, is that there are students in those schools who need access to those services. And as we just had this conversation about the changes in our newcomer population and the influxes that we have schools now that are seeing tremendous changes in numbers, upticks in numbers of students who are very, very high need. And those numbers their numbers are changing not just year to year, but like month to month, week to week in some of these schools. And so, that's a population that we have to be sure that we're not missing. And I think you make a fair point that, we're looking at some different schools where the insured versus uninsured population is different. However, I think the fundamental question is well, not the fundamental question, but the question that relates to that particular issue is whether those students who are, again, currently seeking care, the families who are going to their private practitioners, they have insurance, they've got their routine, they've got their family, are they really going to stop seeing those folks in order to take advantage of this program being within the schools? And so as we look at, the other schools, I think the question, there are kids there are families there who have those relationships, who have insurance and all. Are there, of those families, is there evidence that a bunch of them are switching from their private practitioners to use, the county facilities within the school? I don't know that we're seeing that reflected in the numbers. I don't know if that analysis has been done, but I'm really concerned about the scaling back of this space because, you all have done the work to find a system that works at reaching these kids. This is one of the greatest needs that my office is hearing, is access to healthcare services, access to mental health services, and especially within this most vulnerable population. And when we don't provide that, it impacts everything. It impacts how kids do academically. It impacts our public safety space. It impacts outcomes across a host of issues. So I just want to make sure we're being very, very thoughtful about making sure that we are increasing and not decreasing accessibility to those services, and that I certainly don't want to decrease accessibility there if there's not like a really, really, really compelling reason, evidence-based reason. And I don't know that I am seeing that here, but I want to give you an opportunity to respond.
Yeah, I mean, there's a chart in your packet that lists all of the school-based health and wellness centers, elementary schools and the high schools, and the visit numbers by month. And so this is about, on average, $500,000, $400,000 per school per year to run the somatic component of that. And in places where we're seeing 50 kids, 33 kids a month, in locations where healthcare access is low, our assumption is, and I know that's probably not the right thing to talk about during budget times, but if we're putting them in schools where they have higher access, will those numbers be even lower? Because the highest numbers of students we're seeing in all of these sites are uninsured kids or kids with students with Care for Kids. And so there's it's more likely that there's fewer of those students to access that care in some of the other high schools that we would be putting these in. And so if we're seeing 35, 40 a month at one site, if we put it in a place where most of the kids have access to care, we're likely to see 5, 6 students a month. And for $400,000 a year, is that worth it? So those are all conversations that we have.
That's a different reason than we were talking about a minute ago. So I understand that, and so now that's a question about how much money is this service worth per kid, which is a difficult question, but it's budget season, and we got to ask these questions. I look forward to returning to this later. Yep. Thank you.
Thank you.
Yeah, I was just going to say also, one of the questions in this is, will there be access for these kids? And from my understanding is there's going to be changes to the eligibility processes at other schools. So I think when we come back, we can talk about all the different.
Yes, and that was mentioned in the previous session, but I think that's not the same level of accessibility. Like realistically, that's not going to be accessed the same way. I don't think. Thanks.
Something important to come back to for sure. I'm going to go quickly to Councilmember Sales, then Councilmember Luke.
Yeah, so my question was similar. Have we thought about a model for billing the insurance of those who do seek the services that do have private insurance?
Yeah, and in fact, now we're working with our county attorney's office to enter into contracts with private third-party payers, Care First, Aetna, those insurance companies, in order to allow us to get reimbursed. Right now, you'll see in the chart where it says non-billable, it's not that it's officially non-billable, it's just that we're not going to get reimbursed because they're private insurance, and private insurance does not reimburse school-based health care without a contract. And so we are currently in the process of doing that now. We have a waiver from the state for Medicaid, and so we do get reimbursed by Medicaid for school-based health care services. We're entering into now the third-party payer contracts that will allow us as part of their network to get reimbursed. So outside of network, the parents would be responsible for submitting that information if we build them, submitting that information to their insurance company for reimbursement. But with contracts, we can bill the insurance companies directly.
Oh, good. No, and then how are we getting the information out about the wellness centers, resources and services to the students and families?
Sure. So at back to school, every year there's always a table that for those parents who come to back to school. There's other outreach efforts that are made specifically for the ones we have because we have somatic services and the PYD and mental health services. Everyone works together. There's a huge word of mouth marketing that happens between the students. If you walk into any high school wellness center during lunchtime, you'll see it's packed with all the students who are hanging out in our wellness centers during that time. And because of that, the word kind of gets out to everyone. It is there is an enrollment packet that comes with that. In order to receive the services, the parents have to agree to that their students can be seen for healthcare services, that they can receive that we will keep everything confidential, all the HIPAA forms, they have to sign all those things. So we also send out packets home to new students. And also if a student comes into the health room who's not feeling well, who's not enrolled in the school-based health center or wellness center, a packet is sent home to them as well. Or we get on the phone and say, we have this service, we can see the nurse practitioner now, if you give your verbal agreement, and then we'll send them a packet that they can sign and send back the next day. So we get the word out at every opportunity we can.
Okay, and how are we evaluating the success or the effectiveness of these wellness centers for our students and the families that are using them?
So the main marker that we look at is the ability to return to class. And so if students come into the health room without a wellness center or without a school-based health center and they don't feel well, parents are called and their parents come pick them up, or they drive themselves home in high school or whatever. For those sites that have a school-based health or wellness center, they're able to see the nurse practitioner. The nurse practitioner is able to say, here's an antibiotic, or here's a Tylenol, or here's an allergy medication, go back to class. And so the main thing we look at is the number of students that receive the services who are able to return to class versus being sent home. We also look at asthma rates. A lot of students who are in absenteeism as a result of asthma, if their asthma can be managed in the wellness center because the nurse practitioner and nurse can provide nebulizer treatments on site as opposed to having to go home for a nebulizer, things like that, that we also look at as success.
Thank you.
Yeah, I know we're going to be doing the capital budget for these high school wellness centers, and so I haven't. Are we going to cover that today?
Well, that's what we're discussing now. We just approved the building of one at Woodward to support Northwood students. The other item is a recommendation for a feasibility study for at Key Middle School for Linkages to Learning school-based health center. So that's the other.
Linkage to Learning program, not the school-based.
Sorry, Linkages to Learning program. So that's our other item. Can we? Okay, thank you. And
Thank you.
Councilmember Luke, I know you had a quick point you wanted to make.
Yeah, I'm gonna try to do this as fast as humanly possible. All right, so just wanting to make sure everyone's on the same sheet of music, that insured patients, students, can still get care at the wellness centers, and that's a very important piece, because we are in a landscape where even if you might have a relationship with a pediatrician, like I do, my kids see them once a year for their well visit, and there is no chance on earth that I can ever get them in for a sick visit. I am not alone. I know this is the case of many parents out there, right? And when the thing is going sideways, or the person that goes to the school nurse and you're pretty 99% sure they've got strep, the ability to be able to get them on their antibiotics quickly helps them, again, return to the learning environment, less miss school, overall better wellness for the community. And my question was about, you said that you have to get the kids and send the parents home the forms for them to sign. But at what age do you terminate that? Because our law does allow for students to consent to their medical treatment.
Depends on what the medical treatment is. So for family planning services, the parents wouldn't have to consent to that. For mental health services, they don't have to consent for that. But for doing a COVID test, for doing a strep test, those things, a student can't consent to those things on their own. So our hope is that, when we send out the packet, it is for all services. And so the parent is certainly notified if they have a positive strep test, or if they have a positive COVID test, or they broke their leg or whatever. The parents are going to be notified about that. For things like family planning, without the consent of the child for us to share the information, we're not going to do that either. So it does depend on what type of care and the reason a student may walk into the wellness center to receive care, that the consent would need to be made. If it is for family planning, the student can consent to the care on their own, and we allow that.
And so thinking about the big pile of papers that comes home every school year, early September. I know Councilmember Jawando and I both get a large stack. We've got a lot of kids, lots of different colored papers come home. Now, if they've signed that, do they have to sign it every year? Do you require an annual consent or not? Because, again, if you're saying that mental and behavioral health care is in there or family planning care is in the blanket consent form, but then the student reaches the age where they're able to consent for it alone, have they then consented to the sharing of the thing because the parents have signed the form or not signed the form? Do you see what I'm saying? Like, how do you deal with that discrepancy and change in time over who can consent?
Right. Once registered, always registered at that school. If they change schools or they age out of elementary school and there's not a wellness center or school-based health center at the middle school, then they wouldn't. Then the registration goes away. For the consent to share information with the parent, we know that certain services we are not going to, and that's the same for a high school nurse. In a regular health room for a student who may walk in and let people know that or at least let the nurse know that she's pregnant. Right. We wouldn't share that necessarily with the parent without their consent. And so even though there's a piece of paper in that packet that says the parent consents to these services and wants to be notified, we would never do that without the child.
Student, right. The student has the ability to say yay or nay in those circumstances.
Exactly.
Okay.
And our electronic health record also has that same ability. So we can check off confidential. So it doesn't go to the insurance company because as insurance companies.
You get the explanation of benefits.
Right, it comes back to the parents. We don't want that to happen either. So we have the ability to stop that from going to the insurance company.
Okay. Thank you.
Thank you. Really important line of questioning. And just want to underscore for staff, while we approve the item in Woodward, there is hesitation on the strategy here, and I share it on, when we passed Councilmember Navarro's proposal several years ago at the previous council, all of us assumed the idea we would have a full wellness center at every school. I know obviously cost is a factor, but we're going to want to come back to that strategy, and we will have the opportunity to do so as we consider CIP and follow-up sessions. So I just wanted to put that out there. So Ms. Yao, I think let's round out the linkages, and then we'll pause there.
Right. The committee requested information about schools that have more than 600 students and 65% of the student body enrolled in farms. And we received information from the executive that shows that there's one school that meets that criteria. That's Francis Scott Key Middle School. So council staff recommends adding $50,000 to $50,000. Sorry. To the Linkages to Learning and School-Based Health Center and Linkages to Learning PDF. There is a table on page 4 of your packet that shows the number of students where there is 65% or more students enrolled in farms.
Appreciate that. And the other three, Banneker, Brown, and Burnt Mills, their status is how many of those have linkages?
No, this chart is.
Whole list doesn't have linkages.
Exactly.
But we're calling out Key because of the high percentage.
It meets the two criteria.
And it meets both criteria. Got it. Any comments from colleagues? Councilmember Rink, go ahead.
So my understanding for Burnt Mills and others was that the fact that they don't have a capital project coming up is in large part why we don't see a linkages program coming there. Is that accurate?
Right. No, again, the schools that were recommended in the PDF are ones that are undergoing capital projects. Council staff just noted that we do standalone projects, and again, there's schools that have higher needs than some of the ones that are undergoing capital projects. So again, these are those schools that again, at least have higher than 65%.
Mm-hmm. My understanding from the last time we talked about this was that there were schools that we do not do standalone projects anymore. So,
no, it's just the executive didn't recommend any standalone projects.
But there's none recommended. We have done them in the past. It's obviously always an affordability consideration, but there are none recommended in this CIP.
Yeah. Well, this is another one that, like I mentioned last time, I'd like to return to after the operating budget to think about how we deal with those schools where we don't have a capital project and where we don't have funding to do what we would like to do, like linkages wise, but really there is a great need for those services. This is really relevant to the newcomer conversation as well, that, with Burt Mills, for example, they are getting a huge influx of newcomers specifically, but they just had a big capital project. And so I just want to make sure that there is some kind of plan for that particular bucket and category of situation.
Absolutely.
Thanks.
You might have to have a linkages, a light, or, or some other term, or, I don't want to make any terms, but provide services for
Right.
folks.
It feels like right now they just kind of fall off the list, and those families are absolutely crying out.
Absolutely. Thank you. So without objection, we'll approve that. And with great appreciation to everyone who schlepped out here, we'll see you on Wednesday for the remaining items where we'll cover early childhood education in the NDA, and also the remainder of the school-based mental services, linkages, wellness center conversation, cluster projects.
As well as, there's that one CIP
partnerships.
project, but it's the Early Childhood Facility Fund, and so we can do it
Push
then.
that one as well. Okay. In the partnerships piece, yep. So thank you all. With that, we're adjourned.